Okay, we're gonna get introductions. I'm sorry to all our participants for the delay, but I think we're gonna get back on track. My name is Dr. Jorge Ruiz. I'm a geriatrician at Memorial Healthcare System in Broward, Florida. And I have the privilege today of introducing our speaker. Just before we get started, I just want to make sure that when you ask questions, you use the chat button. You don't have a specific button for Q&A, but you can ask the chat button to send your question, and that's usually in the lower right side of your screen. That's the only information. We hope that we'll try to catch up with the presentation, and thank you for being patient. So our speaker today is Dr. Pedro Abizanda Soler, who is a well-recognized geriatrician and researcher from Spain. He's from the University Hospital Complex of Albacete in Castilla-La Mancha, Spain. He's a distinguished, again, researcher. Like I said, he'll be sharing some of his research today about the FRAILMERIT study, talking about primary care interventions for patients with frailty, a problem that is, of course, of special interest to this group. He was trained at the University Autónoma of Madrid in Spain, and also did a specialty in geriatric medicine at University Hospital of Getafe, another prestigious institution in Spain. He has received multiple grant funding to do the research related to geriatric medicine and frailty. He'll be sharing some of that research with us, and has multiple publications in the area of geriatric medicine, and again, specifically on frailty syndrome, and he'll be sharing some of that experience today. Of note is that Dr. Abizanda has also published a book that is a textbook in geriatric medicine in Spanish, and that has been widely used in, of course, many countries, especially in Latin America and countries where Spanish is the official language, and that's, of course, an important accomplishment. And without further ado, I'm going to introduce Dr. Abizanda, who will be talking about primary care-led interventions for frailty. Pedro?
Okay, thank you very much, Jorge, for the nice intervention and presentation. And feel sorry for the delay in beginning this presentation, because I am actually in Toulouse attending the Frailty conference, and my computer here in France has become absolutely mad. So feel sorry for this delay, because it has been my fault and not Jorge's one. Okay. So I'm not able to share my screen, so Jorge will be doing that, and I will ask kindly him to go one slide after the other. Okay. Hello to everybody. Let me talk about primary care-led interventions for frailty. First of all, I will introduce in my speak some 5 to 10 minutes with some general comments. And thereafter, I will go through the FRAILMERIT study that we have just recently finished. And I would like to share with you some interesting results we have obtained here in Spain. As you can see, in the up left position is Spain, and in red is the province of Albacete, where I live and where we have led the study. And then going right, it's my hospital. It's 2 buildings, the university, and the most famous feast of Spain, that is the Albacete feast, that is very famous in here. Okay, so next slide, please, Jorge.
Can you see it?
No.
Oh.
It's stopped in the first one.
Oh, yeah, I can see it here. Now?
No. And it's not in full screen.
Yeah, let me share again. Oh, now.
Okay, this is the second. Okay, so my first ideas will come regarding what do primary care professionals and patients think about frailty. Next slide. Okay. And first of all is what do primary care clinicians think about frailty? How do primary care clinicians approach this management of frailty? And this is a survey that was recently published in 2024 in Age and Aging about CILI regarding the main challenges for primary care. And I think they are absolutely right. And things happen the same in this survey than in Spain, for instance. I think primary care physicians have challenges in managing complexity, and frail older adults are very complex. There is a need of guidelines because there's an absolute lack of guidelines for this kind of patients in primary care. They have problems with medication reviews and with the prescription. That is one of the possibilities for managing these patients. They have not good guidelines for advanced care planning. They have problems with organization of care because the flux of patients and the pathways are not well established. There are also some social issues that in some countries or settings may be difficult to manage. And also there is a need for geriatrics consultation, and the role of this consultation is not also well established. So these are some of the main challenges. Next one. But more than only the challenges of what we do, there are also challenges in what we think. And this is for me most relevant. This is another survey from Age and Aging in 2023, where primary care physicians were asked about what they thought about frailty. And most of them thought that it was more an adjective rather than a diagnosis. And this is critical because if we don't think in conditions or diseases, it will be very difficult that we make right diagnosis. So they have problems in the conceptualization of frailty, different from medical diagnosis. They have problems with the utility of frailty diagnosis, about the risks, the treatment, and the continuity of care. They have difficulties with frailty identification. They don't know very well how to use the tools. They don't have time, how to do the assessments. They have also problems because they think frailty is a chronic and long-term care condition and not treatable. And also they think it's a negative terminology and we should change it. But frailty is as it is, no? Next one. And the last survey is this one about what do older adults, frail older adults think, or robust older adults think about frailty screening in primary care setting. They think in this survey also from BMC Primary Care in 2024 that screening for frailty should be available and free of costs for everyone at 70 plus years of age. But however, they think it should be optional. They think that screening results can only be shared with the permission of the patient, and that the Department of Health and Aged Care should notify people before 70 years of age to conduct their health professional for the screening, the same like we are doing with, for example, breast cancer or colon cancer. Screening should be conducted by a GP, an allied health professional, or a practice nurse, but it should be part of a comprehensive health assessment. And also, older adults think that health practitioners conducting frailty screening should avoid the terms frail and frailty. So again, this happens again. Next, please. All of you know that there are many examples of models of care. Probably the most famous ones are Think Frailty from the Scottish Healthcare Service, or Fit for Frailty from the UK service. You all know the ICOP, the Australian Frailty Network, the Gerontopol. Some of them are based on primary care, like Think Frailty or Fit for Frailty or the ICOP, but some of them are most related to specialized geriatric medicine, like the Gerontopol, but there are many models you know well. Next, please. And what about randomized clinical trials in primary care? I want to show you only 6 slides with the last primary care randomized clinical trials I have found in PubMed. I'm sure there can be others, but looking about special randomized clinical trials in primary care, I've only found 6 of them. Next, please. This is the first one. Probably this is the most important one. It was conducted published in 2023, conducted in Ireland in 6 primary care practitioners, 168 adults aged 65 plus with a mean age of 77. The intervention was 3-month home-based exercise regime, emphasizing strength and also a dietary protein guidance. And as you can see in the figure of the left, the left panel is the intervention group and the right panel is the control group. And you can see how in the intervention group there's a reduction in frail older adults from the pre-intervention to the post-intervention. And the contrary, when in the control group, there's a similar number of participants, of frail participants after the intervention. So this is a positive randomized clinical trial with a odds ratio of 0.23 of protection about frailty and with a number needed to treat of 8.4. Next one. This is another positive randomized clinical trial conducted in 144 participants. And this is after 24 weeks of an intervention that mainly consisted of empowering education, motivational support, social support, and exercise training. It was published in 2024 in BMC Geriatrics. And this was also positive because there was an absolute risk reduction of pre-frailty of 42.8%. Next one. Now there are 2 meta-analyses. This first one was published in 2024 also, and showing how community-based exercises improve health status in pre-frail older adults with an odds ratio of improving of 2.74. And the next one is related to, next slide, please, of the Otago exercise program. This is also a meta-analysis of 10 randomized clinical trials. And this also showed an improvement in the level of frailty when this Otago exercise program was conducted. Next one. However, there are also negative randomized clinical trials. This one was conducted in 468 participants, published in Lancet Healthy Longevity in 2022. And they created 4 groups, one with physical exercise, one with cooking classes. They called it the senior chef group. Another one combining both nutrition and exercise, and another one a control group. And after 24-month follow-up, they could not find differences in the pre to post frailty status in between the 4 groups. So this was a negative randomized clinical trial. And finally, the last one in the next slide, it's a clinical trial with a lot of older adults, 7,000, more than 7,000 from the ELSI Brazil study. And I would like to show you how differently people progress in frailty and pre-frailty regarding hospitalization when the primary care center is a high standard or low standard, because they measured 12 attribute indicators of the primary care centers, and they decided if the primary care was excellent or not excellent. And when the primary care center was excellent, there were less referrals to hospital for frail older adults. However, for robust or pre-frail older adults, there was an increase in hospital referrals. So the results can be seen in different ways, but I think it's different to notice that the excellence or the attributes of the primary care centers also are important in how they manage frailty. Okay, so in the next slide, let's begin moving to Spain. And in the rest of the intervention, I'm going to talk about Spain and our randomized clinical trial Here in the red arrow, you can see Albacete again. This is the city where I live. Next slide. And this is what we're doing in Spain, because since more or less 2012, the Health Ministry of Spain created a special working group for frailty and falls prevention. And I have been working with them since that date. And that yielded a first document that was delivered in 2014 that was called Frailty and Falls Prevention in Older Adults Consensus, because we met representatives from all the communities of Spain, from all the societies of geriatrics, gerontology, primary care, nursing, and social workers. And we delivered this document that explained primary care physicians how to work with frail and pre-frail older adults. After in 2017, 2018, and 2019, we delivered 3 extra documents. The first one was the Electronic Health Record Registry Guidelines for Primary Care. The second one, the guidelines for multi-component physical exercise programs in the community. And the last one, the roadmap for frailty management. And then came the pandemic, and everything was stopped, as you know. And again, in 2021, we met and we yielded another document that was called Recommendations for Frailty Management During COVID Crisis. And finally, in 2022, we published another document called Frailty Prevention Consensus Document Update, that is really an update of the first one of 2014. And this is the one that we have used for our randomized clinical trial. Next. Thank you. This is the document. In this document, there are many clues about how to manage frailty. The first one is this algorithm in which it is represented how primary care physicians have to screen frailty, because we decided to include in the frailty screening only those older adults with a Bartle index equal or greater than 90, so people without disability or dependency in basic activities of daily living, because we thought that if they had a Bartle lower than 90, some slight or moderate disability in basic activities of daily living, they should move to another program like a disability or dependency one. And in those older adults without disability, we recommended to conduct or a frail instrument scale, or a time it up and go, or a gait speed measurement, or a short physical performance battery measurement. Each primary care physician can do what he wants. And then patients are classified in non-frail or frail, and low fall risk or high fall risk. And in each of these 4 categories, there are some screening tests, special, more advanced screening tests recommended, and a treatment also is, or a management is also recommended. Next one. In this consensus document, there are also materials for primary care physicians and also for the general population, for physical doctors, for nurses, and they can have it and they can share it with older adults at their consultations. Next one. All the interventions that have been included in this document come from the most relevant consensus guidelines that are published in the literature, and mainly regarding how to screen older adults, about multi-component physical exercise, nutrition, sarcopenia, vitamin D, obesity, multimorbidity, polypharmacy, inappropriate medication management, social support, healthcare education, or ICTs. Next one. And here is a resume of the most important interventions that are presented in this consensus document update. You can see at the left side of the slide the most important ones that are based on randomized clinical trials and or meta-analysis. Of course, physical exercise is the first one. nutrition, vitamin D, medications, multimorbidity, cognitive impairment, ICTs, and geriatric medicine consultation. And at the right panel, you can see some other interventions that have been described in the literature, but they are not supported by randomized clinical trials or meta-analysis. So we included them, but only as things that primary care physicians had to take care about, but knowing that they are not supported with randomized clinical trials, and they are pain, obesity, dysphagia, anemia, false prevention, vision, hearing, sleep, depression, and emotional well-being. Next one, please. Also, there is an online training program for professionals. It's mainly directed to GPs and to nurses of primary care. There have been many editions. This one is the 5th one, and it's continuing ongoing. It has been prepared by the group, and it shows about across 5 modules, I think it is, more or less everything that they have to know about Frailty. Next. And finally, there's also a high recommendation in this consensus document about where frailty screening and management has to be done. And all the group agreed that probably the first intervention setting, and probably also the most important one, was primary care. So primary care has to be always involved in the management of frailty in our settings. Next one. And this is the reason for conducting FRAILMERIT, because we thought that we had a nice document, that we have many randomized clinical trials, we have many recommendations, but in Spain until now, and in the international literature, and not so many randomized clinical trials based exclusively in primary care have been conducted regarding frailty. This was a project that was a competitive project that was given to us in 2019, and it is registered in clinicaltrials.gov. You have there's the number. And the problem was that it was to be conducted between 2020 and 2022, and the pandemic came and stopped our randomized clinical trial. So we had to begin again from zero. And when we had to re-begin this trial, many primary care settings were not allowed to participate because of the restrictions of the pandemic. So we had to choose new primary care settings. And finally, it was conducted in 6 cities of Spain. You can see there, it's Barcelona, in Madrid, of course, in Albacete, in my city, in Ellín, that is a small village near Albacete, in La Carlota, that is also a small town near Córdoba, in the south of Spain, in Andalusia, and another small city, Tacoronte, in Tenerife, in the Canary Islands. So these were the sites. Next one. The main objective of FRAILMERIT was to analyze the efficacy of a multi-component primary care-led intervention based on the consensus document for frailty prevention of the Spanish Health Ministry I have presented you, to improve frailty and physical function in older adults compared to usual care. And also there were some other secondary objectives, very ambitious, that were trying to know what happened with hospitalization and emergency visits, what happened with new disability, if this intervention was had a positive effect on false reduction, in institutionalization, in the improvement of quality of care, in mortality reductions, and also in reductions in primary care visits, polypharmacy, and healthcare costs. Next. This is the chronogram. We decided there was a baseline visit. Then we conducted a first intervention during 3 months, 12 weeks. Then there was a 3-month follow-up visit. Then we discontinued during 2 months. And then again, we went to another follow-up visit, a 5-month follow-up visit before the patients began another intervention process of another 3 months, 12 weeks, and finally an 8-month end visit. And in each one, we conducted the same measurements and we collected the same variables. Next. So this is the intervention we did in primary care. Probably the most important one was the multi-component physical exercise program. And this was a 2-weekly on-site expert-conducted individualized sessions for 12 weeks, 2 times, okay? And it has to be conducted or by a physiotherapist or by an expert in sports in older adults. The groups were small because people were pre-frail or frail, and the groups were of only 6 older adults. The duration was 45 minutes, and also we provided recommendations for walking in addition to the program. The second intervention was a nutritional intervention program, and the objective was the improvement in the dietary profile. We did not provide supplements, and it consisted of a 2-hour training session for primary care physicians and nurses participating in the trial regarding healthy dietary habits. I will present it to you after. And the third intervention was a Frailty training program delivered to primary care physicians by the research team, consisting on a 2-hour training session explaining the consensus document recommendations quietly and one by one, and letting they make questions. And also the intervention was 2 periods of 12 weeks separated for 8 weeks calm. Next. Okay, this is the physical exercise program. It's very similar to other intervention programs that we have conducted here in Spain, like the mid-frail study, for instance. And it was very easy to conduct because the materials were very simple. They were bands and chairs and things like that. And they were divided in 3 different sessions, so people did not get bored about always repeating the same exercises, and also working different muscle groups in different sessions. The exercise program was progressive, so we did not did the same exercises with the same intensity every time, but every week the intensity of the number of repetitions have to be increased progressively, and we monitored this physical exercise program. Next. These are some examples in the heating part of the program. This is one primary care center, for instance, another one. And in the next, please. This is another with bands, another primary care center using bands, as you can see here. Okay, next. And this is the nutritional intervention. We provided a leaflet to all the primary care physicians with the recommendations. Sorry for the slide because the interventions are in Spanish, but they were based in the pyramid of the healthy diet and also in the healthy dish that is in everywhere. And we provided also not only general recommendations, but also specific recommendations on how to cook the food and how to present it, or how to mix aliments based on a Mediterranean diet and a healthy diet. Next. Okay, this I begin sharing with you some of the results. These are the primary care centers or nodes we included: 4 from Albacete, 1 from Medellín, 2 from Madrid, 1 for La Carlota in Córdoba, 1 in the Canary Islands, and 3 in Barcelona. As you can see, and you can see here how most of the primary care centers included 24 participants because we decided to randomize by clusters in order not to contaminate participants. So when one primary care center had 24 participants, 2 physicians, each one of them with 12 patients, had reached the pre-inclusion screening, they were randomized either to intervention or either to control. And for instance, in one city, in one primary care center, for instance, if there were 2 nodes, one had to be intervention and the other one had to be controlled. So this is the reason for only 24 maximum patients per primary care center. And some of them, the number was slightly lower because in some of them, there were some problems in the application of the inclusion and exclusion criteria, because the inclusion criteria were pre-frail or frail older adults, or a gait speed lower than 0.8 meters per second, and living in the community. These were the only inclusion criteria. Next one. This is the flow chart of the study. As you can see, we conducted 317 screenings, and of these, only 237 met inclusion criteria. 132 were assigned to the intervention group and 105 to the control group. And of these, completed the first period of intervention 191, that were 98 from the intervention group and 93 from the control group. Then to the second period, we had also some more abandons, and only 154 participants began the second period of intervention, 73 in the intervention group and 81 in the control group. And finally completed the second period 135, that more or less you can see is half of the participants that began all the complete program, 82 in the intervention group and 53 in the control group. However, in the squares in orange, you can see the numbers per protocol. Next. Okay, in this busy table, I'm going to tell you more or less the baseline characteristics of the sample. I will go a little bit, I will stop here a little bit because I want you to know how the population was, because for me this is very interesting. 237 participants, mean age was 78 for the total sample, a little bit higher in the control group, but I think that between 79 and 77, things are quite similar. But there's a statistical difference. More or less 2/3 female, 1/3 male. That is according to the number of females and males for this population, so perfect. BMI was a little bit higher, as it was expected, 29.7 for the total sample, and a little bit higher for the intervention group, 30.9 versus 28.1 for the control, but without differences. As you can see, the Charlson index was not very high, so this population was not high comorbidity, only 1.3 of the Charlson index, without differences between control and intervention. But the contrary, the number of drugs was slightly high. You can see that the mean of the number of drugs usually consumed was 7.6 for the total sample, similar between the control and the intervention. However, you know that, for instance, in the Charlson, hypertension is not included or dyslipidemia is not included. The Bartel index, the mean was 97 because one of the inclusion criteria according to our consensus document was that the Bartel index had to be higher than 90 without dependency in basic activities of daily living. And there was a slight, but very, very slight difference between control and intervention. You can see 98 versus 96. So this population was not disabled. And the Lawton index regarding instrumental activities of daily living was not a selection criteria. But fortunately, the level of the Lawton index is absolutely very high, because the Lawton index we used scored from 0 to 8, being 8 absolutely independent in all the instrumental activities of daily living. And you can see that the main score is 7.4, without differences between the control and intervention group. So we have a population that is not disabled at all, neither in instrumental activities of daily living nor in basic activities of daily living. Okay, regarding the scoring of a geriatric depression scale screening, very simple. Between 1/3 and 1 out of 5 of the population had some depressive symptoms. They were able to ambulate independently. The functional ambulation scale equal to 5, so it's absolutely perfect. Ambulation is in more than some cases 85%, so perfect. And this is very interesting. The SPPB, the short physical performance battery scoring, was really in the range of frailty, because the mean score was 7.9, very similar between the control and the intervention group. So not disabled, but in the range of frailty. And SPPB was not an inclusion criteria. Grip strength for the mean population, sorry, not divided in men and women, was 21 without differences. They were well nourished. The MNA short form was 12.6. Very good quality of life. The mean EQ 5D 5L index was 82%, and the percentage of the population with a frailty phenotype with 3 or more criteria, so being frail, was 24.8% in the control group and 26% in the intervention group. Frail was different, but I prefer not to go with this data. Gait speed was in the range of frailty, as you can see, 0.68 in the total sample, and regarding control and intervention, 0.66 and 0.70, but without differences. And most of the population had a gait speed lower than 0.8, almost 85% of the population. So I think that this describes a population of really pre-frail or frail older adults without disability, and this is the population we made the intervention. Next, please. And probably this is the main slide of all my presentation, because this is the main result of our study. You can see the results at visit 2 after the first period of intervention. In visit 3, that is before the beginning of the second period, and in visit 4, that is the end of the study after the second intervention. And you can see how in all the 3 visits, the percentage of participants improving at least 1 point in SPPB or 1 category in the frailty phenotype from FRIT was absolutely better in the intervention group, that is the orange bars, versus the control group that are the blue bars. You can see how in visit 2, only 49.5% of the participants improved, while in the intervention group, 70.4% of the participants improved in the main outcome. This is a relative risk of 1.55. It was significant, of course, and the number needed to treat was 4.8. And what is more interesting is that in visits 3 and visit 4, this difference increases, and you can see how the relative risk for visit 4 is 2.18, and the number needed to treat in this visit is 3.4. So you need to include 3.4 patients to achieve that at least 1 person improves in the SPPB or in the frailty phenotype. Next one. We decided to analyze these differences in a sensitive analysis between pre-frail and frail older adults, and the orange and the 2 orange bars are pre-frail older adults, and the 2 blue bars are frail older adults. the more clear the control group, and the orange one, the intervention group. And you can see how in all the visits there are differences, but the group that was pre-frail presented a higher improvement in the main outcome in all the visits, and this was especially true in visit 4. Next one. We wanted also to analyze separately SPPB and the frailty phenotype, not only together. So we conducted this secondary analysis, always by intention to treat analysis. And you can see how regarding SPPB, the results are very similar. You can see how the NNT in visit 2 for improving at least 1 point in SPPB is 3.7, in visit 3 is 3.3, and in visit 4, it's the NNT is 3.2. So the intervention was clearly beneficial, improving the SPPB. Next one. And similar, And in this figure, there's a representation on the SPPB change in the 4 visits from baseline to the end of the study. The solid lines are the intention to do the analysis, and the dotted lines are the per protocol analysis. As you can see, they are very similar because very few participants moved from the ITT analysis to the per protocol analysis. And you can see how SPPB, and I said previously, was around 8 more or less in this population for both the control and the intervention groups. And from the beginning, the control group, that is the blue one, goes slightly down until a final SPPB of 7.8 in the intention to treat analysis. And however, you can see that how rapidly those in the intervention group grow up in the SPPB. In the second visit, 8.6, in the third visit, 9 more or less, and in the final visit, 9.4 in the SPPB. So you can see visually how one group improved and maintained, and the other one decreased. Next. And this is the same for SPPB and frail and pre-frail older adults. And again, there was a higher improvement in the pre-frail older adults than in the frail ones, mainly in visit 4. Next. Okay, and regarding improvement or changes in the frailty phenotype, you can see how visually also participants in the intervention group improved more, at least one category in the frailty phenotype than those in the control group. However, as this is a very robust and very hard variable, we could only reach significance in visit 3, and in visit 2 and visit 4, no, because the reduced number of participants, I suppose. I think that if we have had probably 300 or 400 participants, this would have been also significant. Next one. And also, again, the same happened with pre-frail and frail older adults. Those in the pre-frail group improved more than those in the frail one. Okay, and next one. I think we're finishing. From the secondary variables, we are still analyzing them. I think we will not have many interesting results, but I'm not sure. But what we could find is that there were some differences in the drugs commonly consumed. You can see here how in the control group there was only a reduction in at least one drug, only in 23.4% of the control group, while in the intervention group there was a reduction in 36.6 in the visit 2. That is really the moment of the intervention when the primary care physician first faces the problems of the pre-frail or frail older adults, and probably the prescription process is more hard. And then you can see how in visit 3 and visit 4 this moves to a lower difference between the control and the intervention group, probably because the intervention has been mostly done in the first period of the intervention. And in visit 2, this was significant, but in the other visits, no. Next. And this is the roadmap of the future where we are going. There will be a new update of the consensus document in 2025, including falls. And I am not sure if this will be a good idea because we have complicated the number of groups for intervention, because we have, according to the new international guidelines for falls, we have created more groups. I think probably for geriatricians, this is outstanding because we have decided what to do with every special group. I cannot show it to you because it is under construction, but more or less the algorithm will be something like you are seeing in the slide. Some green people with low risk of frailty and falls, some between yellow and orange participants with intermediate risk, and some red participants with a high risk of falls and frailty. And another roadmap for the future is, I think we need to increase the real implementation of the intervention in primary care in Spain in real life, because the real intervention is not very high. And in many groups that have participated in FRAILMERIT, they have told us that after the end of the study, most of the participants wanted to continue, so they will continue with the intervention. Next one. Really, the intervention was great in some primary care centers because participants engaged enthusiastically, and some of the primary care physicians received some gifts that were done by the participants, like this one in Cordoba. Next one. And these are my conclusions. I think that primary care-led interventions for frailty are feasible, and I think that FRAILMERIT has demonstrated this. However, I think that the most important thing of FRAILMERIT is that the intervention was presential, not at home, personalized and individualized. And I think these are the most suitable for frailty. The FRAILMERIT study demonstrates the main outcome, that is that a multi-component intervention based on the consensus document of the prevention strategy of the national health system is effective in improving frailty and physical function in pre-frail or frail older adults in the community. That in our model, approximately 50% of the participants included were able to complete the program. And finally, that the intervention was more effective in pre-frail than in frail people. But I think that probably real life knowledge about this will improve our results. And I think this is all, Jorge. The next one. Yes, thank you very much to all of you. And it has been a pleasure, and I am open to questions if you have some. Thank you.
Thank you, Pedro. Let me just stop sharing. And I think we're a little bit out of time, but we may be able to. Well, there's a question of well, the webinar is having in Spanish. Unfortunately not, but congratulations to Dr. Abizanda. Great presentation. Oh, this is a question. Do you think other variables such as gender, age, and education may affect the intervention outcomes? Do you think it could be beneficial to expand this trial with other older populations?
In our study, with our data, we have not noticed differences between different ages and between sexes. Okay, although there were more women, the improvement was very similar between men and women. And we did not measure reliably educational level, so we don't know. However, the intervention was conducted on site, personally individualized. So I think no, there will be no changes between different educational levels.
Another one is in terms of one question, I guess, asked about the sustainability of the intervention plan after the end of the study. And I mean, probably that will this be implemented? You already mentioned about the guidelines that may change based on these results. Can you comment on that?
But you mean about adherence in the future to this recommendation, to this program, or
I guess
what?
I think the way I understand the question is whether this intervention that of course was funded as a clinical trial will be implemented in real life situations and whether that will be sustainable, because obviously there are a lot of resources there that were implemented as part of the intervention.
Oh, that's a nice question. Yes, thank you. I presented these results, the same that I have presented you 10 days ago in the group of the Health Ministry of Spain, and they are very interested in including the results in the next consensus document that will come to light at the end of this year. So in next week, I'm going to begin writing the manuscript that I will send it to a journal. I expect it to be published soon. And if it happens, this will be included in the final consensus document. And I think this is a very hard push to tell physicians and primary care centers that the intervention is feasible and positive. And the healthcare ministry is doing well work, because in some Spanish communities, this intervention is being, or similar interventions are being conducted. In some of them, a physiotherapist is being included in the team of the primary care centers, and in some of them, they are beginning to treat frailty. So I think this is a push, and how many pushes we have, I think we will have a better implementation and sustainability of this kind of programs.
Right. I want to get one more question, and actually the first part of the question was very similar to the question you just answered, but I like the comment about, or the question about the FINGER program. You know, the fingers for dementia prevention, right? That's also a multi-component program to reduce the incidence of dementia, and the original study was a positive study, and since then there have been several studies. I guess what the question is, do you see similarities to the FINGERS program for dementia prevention? I guess for frailty prevention in this case.
Yes, there are, in the sense that all of them are multi-component, but I think this is different from FINGERS, for instance, and sorry.
Right.
Okay. Yes. And because FINGER is more directed to general recommendations for cognitive impairment, and this is more directed to function. We did not work especially with cognition and affect, although, as you know, these kind of interventions, as the one from FRAILMERIT, also intervene in depression or cognitive situation.
Right. That's a very important question too, because I can see the similarities in the sense that we know that cognitive impairment is highly prevalent in patients with frailty. So I'm sure most of your patients were cognitively impaired already. And the merit of your study is that despite that, you got impressive results. And that's, I think makes us very optimistic about implementing this intervention in real clinical settings. So thank you, Pedro. I think we run out of time, and thank you for an excellent presentation. Congratulations for the great results, and of course we are excited about seeing this publishing in a journal, so we can go over the details and generate more ideas for future research. We appreciate your presentation. And
thank you very much, Jorge.
You're welcome. I just wanted to remind our participants that on April 9th, at the same time, I'm sure there's going to be a change of time too with Europe, that they will catch up with the United States time difference of 6 hours, that there will be a panel webinar on oral health and frailty with 3 distinguished panelists, including dental specialists and speech therapists, that will be discussing new developments in oral health and frailty, and I think we invite you to participate on that. I think that's another exciting opportunity to have a discussion about this important topic. And thank you again for participating. We apologize for the some technical issues at the beginning, but we hope to see you next time. Thank you.